Okay, good afternoon, everyone. It's such an honor to be part of this wonderful conference. I would like to introduce myself first because I'm a radiologist working in both private hospital and in the medical school in Bangkok, Thailand. Today, I will discuss about extent of problems and potential benefits associated with incidental lung nodules. With the increasing use of CT scans nowadays, incidental lung nodules are frequently detected and raising concerns about malignancy. As you all know that the respiratory system is highly sensitive to toxic exposures, which over time may contribute to oncogenesis. There are so many risk factors besides smoking that are associated with lung cancer. For example, air pollution, occupational exposures, e-cigarette and vaping, and genetic predisposition, and so forth. So understanding all of these risk factors can help optimize management strategy. PM2.5 has been classified as group 1 carcinogen, and lung cancer in non-smoker is now the 7th leading cause of cancer worldwide, with its proportion increasing as smoking-related cancer decline. And air pollution is the major contributor, with lung cancer deaths increasingly by 30% since 2007. In Thailand, during burning seasons, particularly in the northern region, PM2.5 concentrations often rises to hazardous level, and this raising concern about health problems. Northern Thai women have the highest incidence of lung cancer in Asia, and lung cancer mortality due to PM2.5 exposure is significantly higher in women than in men. E-cigarette and vaping use has surged globally, especially among young individuals who do not consider themselves as traditional smokers. While long-term data is limited, emerging evidence suggests a potential risk of lung cancer, raising concern about whether these individuals should be classified as high risk. More than 25% of lung cancer patients are non-smokers. This is especially true for women. This suggests that being female is in itself a significant risk factor for lung cancer. Non-smoking women in Southern and Eastern Asia have the high prevalence of lung cancer, with EGFR mutation more common in this group. From the Thailand trial, highlight a higher significant risk of lung cancer with those cancer with first-degree familial history, emphasizing that genetic predisposition. Here it is as the example of the patient who non-smoker and quite young. This is a CT from 35-year-old woman. She never smoked, but her brother has lung cancer. So she underwent to have the chest CT and revealed a small ground glass nodule in the right middle lobe. She decided to proceed to surgery, and it turns to be minimal invasive adenocarcinoma. Here is another example of lady. She never smoked, but her older sister has lung cancer. So then she proceeded to a CT and found a ground glass nodule in the left upper lobe. And she decided to surgery, and the final diagnosis is minimal invasive adenocarcinoma as well. One major challenge in detecting incidental lung nodules is overdiagnosis. From the Thailand study, 96.5% of detected lung cancer was stage 0 or stage 1, which is significant higher than the observed in NLST and Nelson studies. The high rates of adenocarcinoma in situ raising concern about overdiagnosis, particularly among never smoking Asian women. This can lead to unnecessary treatments without reducing late-stage disease or mortality. Here, this is the example of potential overdiagnosis. This lady never smoked. She was diagnosed with lung cancer since 2004. Her family denied any treatment, but continued to regular follow-ups. Over 18 years, you can see lung cancer has progressed over time without causing any symptoms. And eventually, she passed away at the age of 83 with heart disease. While most incidental nodules are benign, this detection can lead to unnecessary biopsies, radiation exposure, and psychological distress, make proper risk stratification crucial. Traditional risk model relying heavily on smoking history, while the risk factor like air pollution, vaping, female sex, and genetic predisposition are not consistently included, indicating the need for personalized follow-up strategies. Despite these challenges, detecting of incidental lung nodules still offer potential benefits. Earlier lung cancer diagnosis can lead to improved survival rates. Identification of other lung conditions such as granulomatous disease, inflammatory disorders, and occupational lung disease, allowing for earlier intervention. In conclusion, a comprehensive approach to incidental lung nodules must go beyond smoking history and incorporate environmental and genetic risk factors. Tailored risk models, especially for Asian never smokers, are crucial to optimizing screening and management. Integrating existing guidelines, for example, like Freshnel Society guidelines for incidental lung nodules and Lung Labs for screening nodule, into a single risk stratified model could reduce confusion and enhance consistency in clinical practice. Thank you for your attention.
Thank you, Nitra, for your very nice presentation. I think we still have 4 minutes for some questions. If anybody on the floor has burning question, yeah, please.
Yeah, very interesting case. You show that 18 years. Does that patient have biopsy? It turned out to be lung cancer or other disease? The case you show us, the nodule and become eventually 18 years after.
And
was it proven by biopsy the cancer?
Yes. Actually, in 2004, she planned to have surgery, but at that time she has the cardiac problem. So the family decided to, stop surgery and then, just follow up.
So it turned out to be the lung adenocarcinoma.
Yeah, they have the provement of cancer.
No, without any treatment, right?
No. Okay. We discussed a lot about the treatment with the families, but finally they deny anything, even target treatment.
So the patient died of other disease.
Yes,
okay,
from heart disease.
Thank you.
Yeah, quite an extreme case indeed. There any other question from the floor? Well, if not, I'm asking you one question about indeed the talent study, the epidemiology, which is not that much difference compared to the area where I live in northern Italy. We have very high levels of PM2.5. So is this pollution in that area due mostly to the factories around it, or is there also a domestic pollution that is certified around that? Yeah.
I just to repeat your question. So you're asking not just only air pollution that cause lung cancer, right?
Yeah, if the
in the northern region.
Yeah.
Yeah, there is some studies that they discuss about the radon gas in northern part of Thailand has a higher than the other parts of Thailand. This is maybe another risk factors.
You know, one of the things that concerns me is that lung cancer here seems to be very different from lung cancer in certainly in Western Europe and North America. And so probably lung nodules are also different in terms of the causes and the etiology behind them. So do you think we should manage incidental nodules differently using different guidelines here as compared to Europe?
Thank you.
Okay.
Thank you very much.
So thank you, Nitra.